Um, the talk that was chosen for me was understanding the parable of rheumatic mitral valve repair. And I have to confess, when I was asked to give this talk by my chairman and Dr. Hanif, if he's around there, I didn't want to sound stupid and ask what does parable mean. So, and I looked that up in the dictionary, and parable actually means the story or the fable. And it always go in the Bible where Jesus give his disciples, some stories with remedies at the end. So I would like to thank Dr. Hanif and Dr. Mahdi for giving me this biblical title, and I hope I could raise up to it. My talk, or the content of my talk, will include an introduction. What are the surgical options for such a problem that we do face a lot here in the kingdom, and our experience, just the preliminary results, and a conclusion. It has been said that rheumatic heart disease enters the throat, licks the joints, and bites the heart. And unfortunately, almost 80% of our practice as a cardiac surgeons in the Middle East is actually dealing for solving such a problems. Almost all acquired valvular heart disease in developing countries are probably related to rheumatic heart disease. A major cause of cardiovascular disease, it is a major cause of cardiovascular disease in developing nations. In developed countries and in the Western countries, rheumatic heart disease had declined dramatically, although there has been some certain recent reports that there is a little bit of a rise of rheumatic heart disease, especially in North America. And the main cause of this was not surgical treatment, was not actually even introduction of antibiotic. It was actually just raising the socioeconomic status and the standard of living. So it's just amazing how it's still causing a major problem in our region. How big of a problem is this? Globally, almost around 250,000 a year patients dies because of rheumatic heart disease. Keep in mind that majority of those patients are young adults. It almost always affect patients between the age of 15 to 40 years of age. Annually, we have around 6 million deaths caused by a stroke, or 7 million caused by heart attacks, but those are elderly patients and are above the age of 70. So if you just have this comparison, a lot of young adults are being affected and die because of this problem. Almost around 16 million of patients currently are affected worldwide with rheumatic heart disease, requiring frequent hospitalization and requiring also heart surgery. The worst affected areas are the sub-Saharan Africa and the South Central Asia. The prevalence of rheumatic heart disease, these are a couple of countries in the Middle East. You could see that Sudan is almost 100 patients have had rheumatic heart disease in 10,000 patients. In Saudi Arabia, the prevalence is around 25 per 10,000. 1% of all school children in Africa and Asia and Eastern Mediterranean regions show signs of rheumatic heart disease. Out of those, 35 to 40% of the children will develop cardiac problems. And out of those who develop cardiac problems, almost 50 to 60%, 50 to 70% actually will require cardiac surgery. The number of deaths due to rheumatic heart disease per 100,000 in the Kingdom of Saudi Arabia is almost 5.5. So what is the natural history of rheumatic heart disease? If you just bear with me in this diagram, I'll just go quickly through it. A majority of the patient will have a subclinical sort of an infection, and majority of them will recover if they have only a single attack and they've been covered with penicillin. But unfortunately, a lot of those patients will have recurrent subclinical infections, and what will happen is they will develop thickening of the leaflets, thickening of the cord, and most probably will present at a later stage with mitral valve stenosis. If the clinical infection was so severe, the patient will immediately present with severe mitral valve regurgitation, and that might require actually surgical intervention even in the acute state, which, by the way, the results are really bad. But what will happen the majority of the time, patient will recover from this infection and will develop other subclinical infection that will lead to mitral valve regurgitation and later will develop to mitral stenosis. If you look at this pendulum in this diagram, it shows you that the majority of the cases presented in childhood will actually develop mitral valve regurgitation. Patients become older, thickening of the leaflet continuous, not only the leaflet but the cords, and the patient will also develop later either mitral valve stenosis or mixed lesion, mitral stenosis and regurgitation. And in our practice, the majority of the time, what we see it actually the mixed lesion, where patient will have the mitral regurg stenosis, and not uncommon we see the severe mitral regurgitation, especially in the younger population. This is a picture of a patient with severe mitral regurgitation. It was a 12-year-old patient who actually was admitted with acute rheumatic fever, severe mitral regurgitation, and almost in cardiogenic shock. They tried their best to treat this patient medically, but unfortunately they couldn't. And what you go and you see in the OR is redundancy in the anterior leaflet of the mitral valve, which is almost always the case, different than the myxomatous valves, where the redundancy is actually in the posterior leaflet. And you see this fibrinous debris on the leaflet caused by the inflammation process. So patients younger than the age of 20 predominantly will present with mitral regurgitation. Middle-aged patient, because of repetitive infection and thickening of the valve, will develop this picture, which is called the fish mouse appearance, and mainly both posterior and anterior leaflet are thickened, the commissures are fused, and it gives you that picture of a fish mouth. And those patients, majority of the time, are stenotic, but actually also have a mixed type of a lesion, stenosis and regurg. It is clear in multiple studies that secondary prophylaxis with penicillin, especially in patients who have an attack of rheumatic heart disease, reduces the recurrent streptococcal infection and actually might minimize the progression of valvular heart disease. Usually all those patients are being seen by the heart team, especially if the indication of mitral valve surgery arises. And majority of the time, the indication, patients with drop of, symptomatic patient, drop of ejection fraction below 60%, and if the end systolic dimension is above 40 millimeter. And all of those cases are discussed in the cardiology cardiac surgery conference for the best plan of management. Of course, nowadays, majority of the patients are with mitral valve stenosis, especially if it's caused by rheumatic heart disease, are dealt percutaneously with ballooning of the mitral valve. But if they do have regurgitation or mixed lesion, it's a surgical situation. So what is the current surgical options for managing those patients? Again, as discussed before with the previous speakers, we also have the two options of either we're going to repair those valves or we're going to replace those valves. I would like to just make a difference with Dr. Lee. He was talking about mitral regurgitation in ischemic heart, which is a totally different scenario than rheumatic heart disease patients. So to the audience, just keep this in mind when we're dealing about, yes, it's the same type of lesion, which is mitral regurg, but the cause is totally different. This is a patient who had a mitral valve repair, and this is a patient who actually we're explanting a mechanical valve from. Mitral valve repair is a well-recognized procedure, and it's the procedure for choice for patients with degenerative mitral valve. We are all aware, the superiority of mitral valve repair in those patients. It has better mortality, better morbidity, better hemodynamic characters and status, and better preservation of the left ventricular function. And it does improve late survival and the likelihood of valve-related complication. Keep in mind, patients with mechanical valve had to be on anticoagulation. Comes the question is repairing mitral valve in rheumatic heart disease, which is a major problem. And why is this? Those patients continuously have a recurrent type of infection, and the durability of the repair is under question. There was few studies, early 70s and mid and early 80s, which actually showed that the repair of mitral valve in rheumatic patients was not as good as we expected. And by the way, the controversy actually exists till now. Which is the best way to go? Do we repair those patients or do we replace those patients? And it all depends, of course, on the patient's character, patient situation, and how would you choose your patient and the decision on that. Mitral valve repair on those patients, the main issue is, especially if you're dealing with mitral stenosis, balloon valvuloplasty is known, but in a lot of countries, open closed commissurotomy is still being used, especially in India and in Egypt. And they do have good results for elevating the mitral valve stenosis. We in our hospital do not use closed commissurotomy, and those patients mainly go to the cath lab if the echo shows that these valves are feasible for ballooning. Mitral valve repair, especially in rheumatic hearts, is not a simple procedure. It actually involves multiple steps, and it involves commissurotomy. What we mean by commissurotomy is actually opening the commissures, because majority of those patients, because of repetitive inflammation, the commissure, which is the joints at the edges between the anterior and posterior leaflet, get fused, and these commissures has to be opened. Unfortunately, it's not that simple, because the subvalvular apparatus is also affected. You have to deal with actually also papillary muscle splitting, because the papillary and the cords also get fused and become so crowded. So this has to be done. Sometimes you had to do some what we call a fenestration in the cords. The cords get matted together and makes like a membrane. So all of these things has to be released. And this will allow you to have some mobility in the leaflet. And if you're lucky, then that might be it. With addition of a ring, you will actually be okay. But unfortunately, the majority of the time, those leaflets are actually heavily calcified, and excision of these calcified leaflet has to be done and patched. And that makes it a bit of a cumbersome type of a repair, because you're including multiple steps that might take actually a longer cross-clamp time. And imagine if this fails, then you have to re-intervene again immediately by either re-repairing, majority of the time if that's the case, or replacing the valve. Mitral valve repair, as I mentioned, this is a picture of a patient who had almost all steps done, patched the anterior leaflet, patched the posterior leaflet, commissurotomy at the that were fused were done. The subvalvular apparatus were calcified, and replacement of the cord had to be done, and a ring also is applied to preserve your repair. Mitral valve replacement is probably the simple way to go, but unfortunately you're dealing with younger population. And what usually happens, if you put a tissue valve, this happens in about 2 to 3 years. This valve has to be explanted. All these leaflets of that tissue valve get eaten up as if that tissue valve is actually even affected by the process of the rheumatic heart disease. But majority what happens is actually the annulus get affected, and this will also affect the leaflet of the valve. Mechanical valve is not a permanent solution. Those valves get thrombosed, they get infected, a pannus formation could happen. This is a patient that was explanted just 2 months ago. Was a kid that needed a valve replacement at the mitral position because of rheumatic heart disease, and 3 years after developed this pannus formation that was causing significant obstruction. So it is a major problem, not uncommon. We have young patients coming with clotted valves, and either you give them streptokinase, or those patients needs to be taken on urgent basis to the OR for changing these valves. Couple of studies that I'm going to allude to from around the world showing that whatever you do with rheumatic heart disease is acceptable, but probably the way to go is to repair. This is a study from South Africa where 241 patients underwent mitral valve repair, 386 underwent mechanical mitral valve replacement, and 289 underwent tissue valve replacement. The actuarial survival at 5 years were higher for the repaired group more than the mechanical or the bioprosthetic valves. So 90% for the repair group, 76% for the mechanical valve group, and 62% for the tissue valve group. Reoperation of the mitral valve repair was 4.3%, and for the bioprosthetic valve was about the same, 5.7%, and actually less for the mechanical valve, which is 1.5%. This is a study that shows you mitral valve repair is almost comparable to replacement either with a tissue or a mechanical valve. This is another study from South Korea. A patient with rheumatic heart disease, 122 patients had mitral valve repair, 418 patients had a mechanical valve replacement. 10-year survival were similar for both groups. 10-year freedom from reoperation were again similar, which is a bit strange, even with the repair, 97% and 94%. But keep in mind, you're talking about two different patients. The patients who had the replacements were older patients, with majority of them had atrial fibrillation and also had tricuspid valve regurgitation that had to be dealt with. This is a study from Australia where they deal with a lot of young females coming with mitral valve regurgitation or stenosis because of rheumatic heart disease, and they feel that the best way to do is to put a tissue valve in those patients. That's their experience. Here in the kingdom, Dr. Zahir Al-Halis at King Faisal Specialist Hospital in Riyadh had two studies that was done in the early mid-90s, and their conclusions were that mitral valve repair, although associated with higher redo surgery and reoperation as compared to valve replacement, however, mortality at the time of redo were actually less with the repaired valve than the one that were replaced. One major advantage of mitral valve repair over replacement is the avoidance of the need for anticoagulation, especially if you're dealing with patients that's coming from rural areas and difficult to monitor their anticoagulation. This is a study in France. 951 patients with rheumatic heart disease underwent mitral valve repair, 2% mortality. Actuarial survival was 89% at 10 years and 82% at 20 years. Excellent result. Freedom from reoperation was 82% at 10 years and 55% at 20 years. 83% of reoperation was because of restenosis of the valve. Study from India showing that again, mortality and repair are acceptable, but keep in mind that freedom from moderate or severe MR was only 32% at 10 years. So a lot of those patients actually become regurgitant, but for whatever reason, not being dealt with. Here, when I was asked, we looked at our data. This is just a preliminary sort of a quick data. We haven't looked at the details or the actuarial survivor. King Faisal Specialist Hospital, Jeddah, we started in July 2000. We had 751 mitral valve rheumatic heart patient. By the way, almost 65 to 67% of our valve practice is rheumatic. 592 were replaced. Majority are mechanical valves. We have done 159 repair. The youngest, because of rheumatic heart, were 6 years of age, and the oldest was 73 years of age. Majority, almost 60%, were men. This is why you could see that a majority of our patients were getting mechanical valves. We had 11 deaths, hospital mortality. Our mortality was 1.5%, and 4 of those patients were actually patients who came with acute rheumatic activity, severe global myocardial dysfunction with severe regurgitation at the mitral valve. The cardiologists, I must say, tried their best to cope with this patient but couldn't, so we decided to take those patients to the OR. And usually the same scenario, you finish the procedure, patient for 4 to 5 hours do very well, and then suddenly start decompensating. You have to put those patients in ECMO, and all the ECMO sequelae of bleeding, stroke happened. So we had 4 patients who died. 1 patient had an LV rupture. This is a patient who had a tissue valve put in before for a mitral valve, rheumatic heart disease. And at the time, one of the struts was actually pushing on the posterior wall of the ventricle, causing some thinning out. So the valve was removed, another mechanical valve was put in, and 8 hours after, the patient suddenly had a gush of blood from the chest tube. We took this patient back to the OR. We find that tear was repaired, but the patient developed DIC picture and died a couple of days after. 6 patients developed infectious sepsis, multi-organ failure, and those were elderlies, patient rheumatic heart disease, renal dysfunction. 2 of them were on hemodialysis before. Out of those group of patients, the 751 that we have done, 76 came back for redo replacement. I don't have the exact timing, and is it from the patients who had the repair or patients who had the replacement? The data, we're still looking into that. So failure around 10.2%. But keep in mind that our practice is not all of our patients who fails a repair or needed something is actually back at our hospital. Some of them go to other hospitals, so full information I don't have yet. Maybe next time, next presentation, I'll have the full data. So in summary, rheumatic heart disease is a leading cause of heart problems, especially in young adults and patients below the age of 40 in our kingdom. Majority of our cardiac surgical practice is actually dealing with those patients. Acute rheumatic fever causes pancreatitis affecting valve leaflet, and the first valve affected is the mitral valve with severe mitral valve regurgitation. Probably mitral valve repair, when it is feasible and possible, is the way to go. It does have mid and long-term good functional results. So patient selection has to be very careful in tackling those patients. Problem, if those patients are not covered with antibiotic, repetitive attacks of rheumatic fever affect the repair very badly. Factor that influence negatively the outcome, this is from the group of Riyadh results, is the acute phase of rheumatic fever, young age, and the complexity of the repair. And if there is a mitral valve that regurgitation that being ignored for a long time. Of course, surveillance for those patients is lifelong. And I think, although I do know there is a national programs to raise the awareness of rheumatic heart disease, prevention, and providing of a good care for those patients. Lastly, what's the future and the innovations? I wish, tissue valve engineering and all of this could have played a role. But unfortunately, just a few weeks ago, I read a paper. I think, Dr. Lee, you were one of the reviewers of it, that tissue valve, engineered tissue valve, although it was probably a few years ago a hot topic, but unfortunately, it looks like it's still failing dramatically. I think with this, I come to my end of my talk.